The theme of our lecture is clinical pharmacology of drugs used in chronic obstructive pulmonary disease, COPD, and bronchial asthma. Let's define what asthma is according to GINA. Asthma is a chronic inflammatory disorder of airways. Many cells and mediators are involved in this process: eosinophils, mast cells, and T lymphocytes. Mast cell activation by allergens and physical stimulus mediators such as histamine, LTD4, and prostaglandin D2, tumor necrosis factor alpha. These mediators lead to bronchoconstriction, airway narrowing, airway wall thickening, increased mucus. Chronic inflammation leads to structural changes, including subepithelial fibrosis, basement membrane thickening, airway smooth muscle hypertrophy and hyperplasia, angiogenesis and hyperplasia of mucus-secreting cells. Chronic inflammation is connected to bronchial hyperresponsiveness. Common asthma symptoms include coughing, especially at night, wheezing, shortness of breath, chest tightness, pain, or pressure. COPD definition by Gott. COPD is characterized by decreasing flow in airways, bronchial obstruction, which is not completely reversible. Bronchial obstruction is in progress and is connected with abnormal inflammatory response of lungs, caused by toxic pollutants. Greater than 90% of COPD in developed countries is related to smoking. COPD symptoms: chronic cough, excessive sputum production, wheezing, dyspnea, poor exercise tolerance. COPD involves inflammation of the respiratory tract with a pattern that different from that of asthma. In COPD, there is a predominance of neutrophils, macrophages, cytotoxic T lymphocytes, and T helper 70 cells. The inflammation predominantly affects small airways, resulting in progressive small airway narrowing and fibrosis, chronic obstructive bronchiolitis, and destruction of the lung parenchyma with destruction of the alveolar walls, emphysema. In contrast to asthma, the airflow obstruction of COPD tends to be progressive. Thus, the predominant inflammatory cells in asthma include eosinophils, mast cells, CD4 T lymphocytes. The predominant inflammatory cells in COPD include neutrophils, CD8 T lymphocytes, macrophages. Airflow limitation in asthma reversible, in COPD irreversible. Differential diagnosis: COPD and asthma. COPD, onset in midlife, symptoms slowly progressive, long smoking history. Asthma, onset early in life, often childhood. Symptoms vary from day to day. Symptoms worse at night, early morning. Allergy, rhinitis, and or eczema also present. Family history of asthma. Approaches to treatment. 1. Blockade of constrictor neurotransmitter, bronchodilators. 2. Suppression of inflammation, corticosteroids, leukotriene antagonist, mast cell stabilizers, IgE neutralization, reagin antibodies, anti-interleukin 5, roflumilast. 3. Mucoregulators. Drugs may be delivered to the lungs by oral or parenteral routes and also by inhalation. Inhalation is a preferred mode of delivery of many drugs with a direct effects on airways, particularly for asthma and COPD. 3. Abuse advantages. Therapeutic effects are enhanced. Systemic effects are minimized. A relief of acute attacks is rapid. Inhalation drug therapy. Inhalation therapy deposits drugs directly but not exclusively in the lungs. Distribution between lungs and oropharynx depends mostly on the particle size and the efficiency of the delivery method. Most material will be swallowed and absorbed, entering systemic circulation after undergoing in the first pass effect in the liver. Some drug will also be absorbed into the systemic circulation from the lungs. Use of large volume space will reduce the amount of drugs deposited on the oropharynx, thereby reducing the amounts swallowed and absorbed from the gastrointestinal tract, thus limiting systemic effects. Aerosol deposition depends on the particle size, the pattern of breathing, and the geometry of the airways. The optimum size for particles to settle in the airways is 2 to 5 micrometers. Particles over 5 is deposited in the mouth or pharynx. Particles under 1 or 2 micrometers remain suspended and may be inhaled. There are three common types of aerosol generation are used for inhaled drug delivery: the pressurized metered-dose inhaler and respimat, the dry powder inhaler, the small volume nebulizer. Let's look at the group of drugs. Bronchodilators. Bronchodilators are central in the treatment of airways disorders. Currently, three main classes of bronchodilators are available: beta-2 adrenoreceptor agonists, muscarinic receptors antagonist, and xanthines, which can be used individually or in combination. Beta-2 agonist, treatment of acute asthmatic attacks. Muscarinic antagonist, less useful in asthma, used for treat COPDs. Methylxanthines long-term prevent bronchoconstriction. Beta-adrenergic agonist. There are non-selective beta-agonists: epinephrine, ephedrine, isoproterenol. Above-mentioned drugs are non-selective and thus are not preferred. Tachycardia and increase in the blood pressure are their side effects. Selective beta-agonists, adrenoreceptor agonists are mainstays in the treatment of asthma. Beta-agonist mechanism of action. Adrenoreceptors agonists are binding to beta receptors on airway smooth muscle cells, stimulators adenylyl cycles, and increase the formation of intracellular CMP, thereby relaxing airway smooth muscle. Inhibiting release of bronchoconstrictor mediators from mast cells, inhibit microvascular leakage and increase mucociliary transport. Classification. There are short-acting beta-2 agonists. Maximum effect occurs within 15 minutes. The duration of action is 3 or 5 hours. They are usually used on an as-needed basis to control symptoms. Albuterol and terbutaline are also available in oral form. On this slide, you can see short-action reliever's SABA, short agonist beta-2 adrenoreceptors, salbutamol and brand name Salamol, salbutamol and Ventolin, terbutaline and brand name Bricanyl. The next group of drugs is long-acting beta-2 agonist with duration of action 12 hours or more. Salmeterol, formoterol. They are used twice daily. These are given by inhalation. Formoterol also has a rapid onset of action of around 20 minutes. They are used in patients with asthma and COPD. On this slide, we can see LABA, salmeterol and brand name Servient, Meterol, formoterol and brand name Oxys, Turbuhal, and Foradil. Ultra-long-acting beta-2 agonist with duration of action 24 hours. Indacaterol, olodaterol, vilanterol. They are currently FDA approved only for the treatment of chronic obstructive pulmonary disease, COPD. Side effects of beta-2 agonist: muscle tremor, direct affection skeletal muscle beta-2 receptors, tachycardia, direct affection atrial beta-2 receptors, reflex effect from increased peripheral vasodilatation via beta-2 receptor, hypokalemia. This is due to receptor stimulation of potassium entry into skeletal muscle, restlessness, hypoxemia, metabolic effects, increased glucose, lactate, tolerance, which may be due to downregulation of receptors. Clinical use: short-acting beta-2 agonists. Inhaled SABA has been first-line treatment for asthma for 50 years. Regular or frequent use of SABA is associated with adverse effect. For safety, GINA no longer recommends SABA-only treatment for step 1. This decision was based on evidence that SABA-only treatment increased the risk of severe exacerbations and that adding any inhaled corticosteroids significantly reduced the risk. Clinical use: long-acting inhaled beta-2 agonist. In asthma, LABAs should always be used in combination with inhaled corticosteroids in a fixed-dose combination inhaler. In COPD, LABAs are effective bronchodilators but may be used alone or in combination with anticholinergics or ECS. Indecaterol, vilanterol, and olodaterol, with a duration of over 24 hours, are more effective in patients with COPD than twice-daily LABAs and more frequent SABAs. Anticholinergic drugs. Mechanism of action. Anticholinergic drugs cause bronchodilation by blocking M3 receptors-mediated cholinergic constrictor tone, act primarily in the larger airways which receive vagal innervation. This effect is small in normal airways, but is greater in airways of patients with COPD, which are structurally narrowed and have higher resistance to airflow. Classification: short-acting muscarinic antagonist, SAMA, ipratropium bromide, duration 4 and 6 hours. The onset of bronchodilation in 30–60 minutes after inhalation. A long-acting muscarinic antagonist, LAMA, with duration of action 24 hours. Tiotropium bromide, glycopyrronium bromide, umeclidinium bromide, and eclidinium bromide. On this slide, you can see drugs in inhalation form and their brand name. On this slide, you see different forms of inhaled drug delivery. For example, Spiriva HandiHaler, Spiriva Respimat, Sibri Breezhaler, Incrus Ellipta. Many patients with COPD need a combination of inhaled medication. There are the following combinations: SABA and LAMA, for example, albuterol, ipratropium, ipratropium plus levosalbutamol, LABA and LAMA, dual combination inhalers including indecaterol and glycopyrronium, vilanterol and omeclidinium bromide, olodaterol and tiotropium bromide, formoterol and glycopyrronium bromide, formoterol and eclenidium bromide. There are additive bronchodilatator effects between anticholinergics and beta-2 agonists in patients with COPD, which has led to the development of fixed-dose combinations. Complementary actions of beta-2 agonist plus anticholinergics. Possible additive synergistic activity, fast, greater and prolonged action of bronchodilation, different sites of action, non-bronchodilation effects, improvement in exercise tolerance, effects of mucus hypersecretion. The following combination inhalers are available. For example, spelterispimab, tiotropium bromide and olodaterol. Glycopyrronium plus indacaterol, brand name Ultibro. Umeclidinium plus vilanterol, brand name Noroelipta. Anticholinergics side effects. Inhaled anticholinergics drugs are generally well tolerated. LAMAs cause dryness of the mouth in 10% of patients, but this usually disappears during continued therapy. Urinary retention is occasionally seen in elderly patients. Nebulized ipratropium bromide may precipitate glaucoma in elderly patients due to a direct effect of a nebulized drug on the eye. Anticholinergics may reduce secretion and lead to more viscous mucus. Clinical use. Anticholinergics are more effective for COPD than for bronchial asthma. Their relatively greater effects in COPD than in asthma can be explained by the inhibitory effects on the vagus nerve tone. These drugs reduce air retention and improve exercise tolerance in patients with COPD. Anticholinergics are frequently used as an additional bronchodilator in patients with asthma not controlled by LABA. A muscarinic antagonist should be considered when inhaled beta-2 agonists cause unpleasant tremors in elderly patients. There are long-acting inhaled bronchodilators. The next group of bronchodilators, methylxanthines, pharmacological effects. This group is blocked of adenosine receptors. Adenosine is a bronchoconstrictor. Inhibition of enzyme phosphodiesterase. Increase contraction of diaphragm. Improve ventilation. Adverse effect. Increase heart rate, increase force of contraction, increase gastric acid secretions, increase renal blood flow, weak diuretics action, stimulant effect of respiratory scent overdose, tremors, nervousness, insomnia, convulsion. Classification. Short-acting, duration 6-8 hours. Aminophylline. Theophylline is given by oral route and aminophylline is administered by slow intravenous infusion. Long-acting, duration 12 hours, theophylline, theolong, duralin, theob, and others. It has narrow therapeutics index. Nebulized beta-2 agonists are now preferred over intravenous aminophylline for acute exacerbation of asthma and COPD. Sustained-release theophylline can be used in mild to moderately severe asthma as a third line of alternative adjuvant drugs, especially in patients with nocturnal asthma. It is more useful in COPD, is often added to other drugs. Oral immediate release theophylline tablets or elixirs, which are rapidly absorbed, give wide fluctuation in plasma levels. Use of intravenous aminophylline in status asthmaticus is outmoded. Next group anti-inflammatory agents include glucocorticoids, leukotrienes antagonists, mast cell stabilizers, anti-immunoglobulin E monoclonal antibody, anti-interleukin 5, PDE inhibitors, loflumilast. Anti-inflammatory agents reduce the number of inflammatory cells in the airways and prevent blood vessels from leaking fluid into the airway tissues. By reducing inflammation, they reduce the spasm of airways and bronchial hyperreactivity. Glucocorticoids mechanism of action. At a molecular level, an ICS switches off activated genes that encode for inflammatory proteins, such as cytokines, adhesion molecules, and enzymes. Inhibition of phospholipase A2, therefore, increased prostaglandin and leukotrienes, increased number of inflammatory cells in airways, mast cell stabilization, and increased histamine release, increased capillary permeability and mucosal edema, inhibition of antigen-antibody reaction, upregulate beta-2 receptors, have additive effects to beta-2 agonists. Pharmacological actions of glucocorticoids. Anti-inflammatory action, useful effects. Immunosuppressant effects, useful effects. Metabolic effects, side effects. Hyperglycemia, increased protein catabolism, decreased protein anabolism. Stimulation of lipolysis, fat redistribution. Mineralocorticoids effect, sodium fluid retention, hypertension, increased potassium excretion, hypokalemia, increased blood volume, hypertension. Inhaled steroids include beclomethasone, budesonide, mometazone, fluticasone, cyclophosphamide, flunisolide. How quickly do inhaled corticosteroids work? Some improvement in asthma symptoms can be seen in 1 to 3 weeks after starting inhaled steroids, with the best results seen after 3 months of daily use. Pharmacokinetics. The fraction of steroid that is inhaled into the lungs act locally on the airway's mucosa, but may be absorbed from the airway and alveolar surface. Thus, a portion of inhaled dose reaches the systemic circulation. The fraction of inhaled steroid that is deposited in the oropharynx is swallowed and absorbed from the gut. The absorbed fraction may be metabolized in the liver, first pass metabolism, before reaching the systemic circulation. The use of a space chamber reduces oropharyngeal deposition and therefore reduces systemic absorption of ICS. Beclomethasone dipropionate and cyclophosphamide are prodrugs that release the active corticosteroid after the ester group is cleaved by esterases in the lung. Budesonide and fluticasone propionate have a great first-pass metabolism than beclomethasone and are therefore less likely to produce systemic effects at high inhaled doses. Cyclophosphamide. It is a prodrug that is converted to the active metabolite by esterases in the lung, giving it a low oral bioavailability and a high therapeutic index, soft steroid. Fluticasone 4-8 has the longest duration of action and is suitable for once daily dosing. Fluticasone is the most potent inhaled steroid available. Currently, there are combinations of beta-2 agonists with corticosteroids. For example, budesonide and formoterol, brand name Symbicort, fluticasone and salmeterol, Advair, fluticasone and vilanterone, Breville, Ellipta, formoterol and mometazone, Dulera. Now widely they used in the treatment of asthma and COPD. In asthma, combine a LABA with corticosteroids offers complementary synergistic actions. The combination inhaler is more convenient for patients, simplifies therapy and improves adherence with the ICS. Also, delivering the two drugs in the same inhaler ensures they are delivered to the same cells in the airways. Combined inhalers, LABA and CS, and brand name, and dosing, and device. Side effects of inhaled corticosteroids. Local side effects. Dysphonia due to atrophy of the local cord following laryngeal deposition of steroids. Oropharyngeal candidiasis, throat irritation and cough. Systemic side effects. Hypothalamic, pituitary, adrenal. Axis suppression depends on dose. HPA suppression with inhaled steroid is usually seen only when the daily inhaled dose exceeds 2000 microgram beclomethasone or its equivalent daily. Those who take inhaled steroid for long-term management have an increased risk of developing pneumonia. Inhaled steroids in asthma and COPD. Inhaled corticosteroids are recommended as first-line therapy for patients with asthma. The dose of inhaled corticosteroids should be the minimal dose that controls asthma. Corticosteroids do not appear to have anti-inflammatory effect in COPD. Systemic glucocorticoids classification. Classified usually by potency and duration of action. Short-acting cortisol and hydrocortisone. Intermediate action prednisone, prednisolone, methylprednisolone, and triamcinolone. Long-acting more than 36 hours. Betamethasone and dexamethasone. Side effects due to systemic corticosteroids: adrenal suppression, growth retardation in children, osteoporosis, fluid retention, weight gain, hypotension, hypoglycemia, glaucoma, cataract, fat distribution, wasting of muscles, psychosis. Next class of anti-inflammatory drugs: leukotrienes antagonists. Leukotriene, produced by the action of 5-lipoiodinase on arachidonic acid, synthesized by inflammatory cells in the airways, eosinophils, macrophages, mast cells. Leukotriene B4, increased neutrophil chemotaxis. Cysteamyl leukotrienes C4D4 and E4 cause bronchoconstriction, increased bronchial hyperreactivity, mucous edema, mucus hypersecretion. Leukotrienes pathway inhibitors consist 5 lipoxygenase inhibitors, zeoliton, and receptor antagonist, zafirlukast, montelukast. Zafirlukast and montelukast are selective, reversible antagonists of cysteamyl leukotriene receptors taken orally. Zafirlukast is long-acting and can be given twice to once daily orally. Have anti-inflammatory action, less effective than inhaled corticosteroids, have glucocorticoids sparing effect. Uses of leukotriene receptors antagonist. They are not effective to relieve acute attack of asthma. They used for prophylaxis of mild to moderate asthma, like aspirin-induced asthma, montelukast, antigen and exercise-induced asthma. Can be combined with glucocorticoids. Additive effects. Low dose of glucocorticoids can be used. Side effects: elevation of liver enzymes, headache, dyspepsia. Let's look at the next class of anti-inflammatory drugs. Mast cell stabilizers act by stabilization of mast cell membrane. Cromolyn, chromoglycate, nedogromin act by stabilization of mast cell membrane, inhibit mediator release from sensitized mast cell in vitro, and also reduce firing of sensory C fibers in response to bradykinin, given by inhalation, aerosol, microfine powder, nebulizer, have poor oral absorption, 10%. Mast cell stabilizers, not bronchodilators, not effective in acute attack of asthma, prophylactic anti-inflammatory drug, reduce bronchial hyperreactivity, effective in exercise, antigen and irritant-induced asthma. Children respond better than adults. Mast cell stabilizers uses. This class is very limited in long-term treatment of asthma. This class of drugs is used to treat allergic rhinitis, conjunctivitis, and prophylactic therapy in allergic asthma, especially in children. Side effects: bitter taste, minor upper respiratory tract irritation. Let's look at the next class of anti-inflammatory drugs, monoclonal antibodies. Today, four types of biologics are licensed for severe asthma: omalizumab, anti-immunoglobulin E antibody, mepolizumab and reslizumab, anti-interleukin-5 antibody, benralizumab, anti-interleukin-5 receptors antibody, and dupilumab, anti-IL-4 receptors alpha antibody. Omalizumab prevents IgE binding with its receptors on mast cells and basophils. Decrease release of allergic mediators. Used for treatment of allergic asthma. Side effects and limitations. Infusion side effects and very expensive. Ads can be given subcutaneously. Its dose is determined by baseline IgE and body weight. In adults, the total IgE, the licensed indication is IgE up to 1,500. Uses: for resistant types of asthma and allergic rhinitis. Reslizumab. Reslizumab reduces exacerbation rates and improves lung function and patient-reported outcomes in patients with eosinophilic asthma receiving therapy per step 4 and 5 of the GINA guidelines. Reslizumab uses: intravenosis over 20-50 minutes every 4 weeks. 80 years and older, severe asthma with eosinophilic phenotype. Mepolizumab and brand name Nucala. Humanized monoclonal antibody against interleukin-5. Uses: subcutaneous injection every 4 weeks, dosing 12 years and older. Reduced severe asthma attacks, hospitalization, prednisone usage. Next class, new therapies. Roflumilast, brand name Daxos is a selective phosphodiesterase 4 inhibitor that decreases systemic and pulmonary inflammation and decrease symptoms in patients with severe chronic obstructive pulmonary disease. The mechanism of action acts as a selective long-acting inhibitor of enzyme PDE4. This causes to increase intracellular CMP in lung and immune cells and anti-inflammatory effect. Daliresp or Daxos is an oral tablet to reduce COPD exacerbations to be taken once daily. A major limitation, side effect, nausea, headache, and diarrhea. Mucoregulators. N-acetylcysteine, effective mucolytic drug that reduce sputum viscosity and elasticity, improve mucociliary clearance and modulates the inflammatory response, has both direct and indirect antioxidant properties, might be important for the long-term management of patients with COPD. Let's talk about asthma management. There are 5 steps to asthma treatment. At the first step, we use, as needed, low dose inhaled corticosteroids, formoterol. Other control options: low dose ICS taken when even SABA is taken. Step 2 includes daily low dose inhaled corticosteroids or as needed low dose ECS formoterol. Step 3. We use low dose ICS and LABA. On the fourth step, medium dose ICS and LABA. Step 5 is usually used for patients who has not got control of symptoms on the previous therapy. It includes high dose ICS and LABA and plus tiotropium, anti-immunoglobulin E, anti-EL5, anti-EL4, Now, let's talk about initial pharmacological treatment COPD. Initial pharmacological treatment should be based on the patient's GOLD group A, B, C, D, determined by the level of symptoms assessed using either CAT or MRC, and number and severity of exacerbations in the last year. This table of GOLD strategy COPD. There are Group A, Group B, Group C, and Group D. Group A, patients with low symptoms, little or no exacerbation. we can use any bronchodilator. It may be short-acting or long-acting bronchodilator. Then the patient's symptoms increases, but exacerbation remains same. The patients will go from group A, group B. They can use either LABA or LAMA. LAMA is better than LABA for exacerbation, but here the number of exacerbation has not changed, has remained the same. Now, when we go from group B to group C, from group A to group C directly, that means the number of exacerbation has increased. So we will have to use a LAMA. When we go from group C to group D, which means same exacerbation but more symptoms. So for symptoms control, we usually add LAMA, but for exacerbation control, if the patient has more exacerbation, then we use ICS plus LABA. So just remember, ICS is for exacerbation and LABA is for symptoms control. Follow-up pharmacological treatment, COPD. Follow-up treatment depends on the current symptom and exacerbation. Now, the main thing that we need to understand is that when the patients come back to us, he may have problems with symptoms, mainly dyspnea or exacerbation of both. When a patient has dyspnea, uncontrolled symptoms, and the patient was initially on LABA or LAMA, we do a combination therapy and we don't need to add steroids because steroids are there just for exacerbation. Coming to right side, exacerbation. When the patient is either or LABA or LAMA, we consider adding steroids. Steroids are maybe useful for patients with higher eosinophils, more 300, or eosinophil more 100, and to moderate exacerbation on 1 hospitalization. Or we make a dual against LAPA plus LAMA. When the dual agent, the exacerbation are not controlled and the eosinophils are less 100, that means steroids won't be helpful. So we go to roflumilast and azithromycin. Azithromycin may be useful and roflumilast may be useful in FeV1 less than 50%. If eosinophils are more than 100, that means steroids might be useful. So we go from dual therapy to triple therapy. And also from triple therapy if the patient exacerbation are not controlled on triple therapy when we go to roflumilast and azithromycin.